So starting with clinical features of GBS, rapidly evolving reflexic, ascending paralysis with or without sensory disturbances in the form of tingling, burning in hands and feet, and this sensory disturbance, it can be patient can have tingling or burning in hands and feet. So patient can present with paresthesias in hands and feet. So this can be present or this cannot be present. And note that patients, in 50% of patients, they can develop bilateral seventh nerve palsy. They can develop seventh nerve palsy, and 30% will eventually develop. They have to. They will be dependent on ventilator for respiratory support. And weakness plateau is within 4 weeks. It's not necessary that GBS will have antecedent events like respiratory or GI infections. It's seen only in 70% of the cases. So 30% of the cases there will be no infections. So what are the risk factors for this ventilator impairment? One is patient having old age. Another is patient having severe weakness at admission. So severe weakness at admission. Third is rapid progression within 24 hours. Fourth is early facial or verbal weakness. So early facial or bulbar weakness, and that too within 1 week of onset. So old age, severe weakness at admission. This is at admission. Severe weakness if the patient is very weak at admission, and if there is rapid progression within 24 hours, and the patient has early facial or bulbar weaknesses, or and that within 1 week of onset. So patient, these are the risk factors for ventilatory support. And other systems, other features that we see in these GBS patients are ANS involvement. So patient can develop postural hypotension or cardiac dysrhythmias. For example, ANS features can be BPs, labile, tachybrady, urinary retention, paralytic ileus, pupillary abnormalities, and pain can be dysesthetic pain in the extremities. So we know that there are various subtypes. One famous subtype is Miller-Fisher syndrome, where antibody associated is anti-GQ1B, and it's seen in children and young adults. It's associated with ataxia. So there is a triad: ataxia, ireflexia, and ophthalmoplegia. Plus there is this pupillary paralysis. There is no weakness as such. So you have to remember this. There is no weakness as such. So let's see one question. A 37-year-old man presents with 3-day history of double vision. So there is this double vision history and unsteadiness in gait. So there is unsteadiness in gait. There is double vision. Double vision and unsteadiness means ataxia, and there is diplopia. He reports, although no limb weakness, there is no weakness. There is no sensory disturbances. And examination reveals there is ophthalmoplegia. There is this bilateral lateral rectus palsy, and there is areflexia, absent deep tendon reflexes, and there is marked gait ataxia, but normal limb strength, no signs of meningism or fever, cranial nerves otherwise intact, pupils are reactive. MRI brain was done, that was normal. CSF showed normal opening pressure, no pleocytosis, mildly elevated protein, and a diagnosis of peripheral demyelinating disorder is considered. Which of the following is the most likely diagnosis? Obviously the answer is Miller-Fisher syndrome. So you see, weakness, they don't come with weakness. There's a triad: ophthalmoplegia, ataxia, areflexia, and onset is often post infectious condition, for example this upper respiratory tract infection, GI infection, CSF will show albuminocytological dissociation, increased protein, although normal cells. And anti-GQ1 antibody, that is anti-GQ1, but it is IgG type. It's highly specific. You see, uh, why botulism is not considered here. Botulism, although can cause ophthalmoplegia, there is ophthalmoplegia, but they usually present with a descending type of paralysis that we encounter in one kind of snake bite. So there is the descending paralysis, there is pupillary dilatation, there is autonomic stem symptoms. So they present with ophthalmoplegia, they present with descending paralysis, they present with pupillary dilatation, and there is autonomic symptoms. Now there is a rare CNS variant of this condition of GBS that has an overlap with Miller-Fisher syndrome. So this bigger stuff is a rare, although it is rare, but it is post-infectious autoimmune disease involving brainstem, considered part of GBS spectrum and closely related to Miller-Fisher syndrome. It can present with ophthalmoplegia, ataxia, hyporeflexia, or hyperreflexia. So it can vary. So in bigger stuff, there can be hyperreflexia or hyporeflexia, but this Miller-Fisher syndrome is always areflexia. And altered sensorium is the one that distinguishes it from Miller-Fisher syndrome or GBS. Always remember this thing: altered sensorium is the one that distinguishes it. And also there will be positive Babinski's sign that will tell that it indicates CNS involvement. Patient can have facial bulbar palsy, respiratory failure, preceding infections are there. An MRI brain may show high this T2 signal in pons, medulla, and midbrain. And note that since it's closely related to Miller-Fisher syndrome, that's why also anti-GQ1B IgG is often positive here. Now let's solve one question. A 34-year-old male presents with acute onset double vision, slurred speech, unsteadiness while walking. He has a recent upper respiratory tract infection 10 days ago. On examination, he is drowsy, but he is arousable. There is bilateral ophthalmoplegia and facial weakness. Ataxia is present, reflexes are absent in all four limbs. He has a positive Babinski's sign bilaterally. MRI brain shows subtlety to hyperintensity in the pons. CSF analysis shows mildly elevated protein, although there are no cells. And anti-GQ1B IgG antibody is positive. So the correct answer for this is Bickerstaff brainstem encephalitis. There is ophthalmoplegia, there is ataxia, there is ophthalmoplegia, there is ataxia, because it's closely related to MFS. But distinguishing features is altered sensorium. There is areflexia, and Babinski's sign is positive, and anti-GQ1B antibody is also positive. CSF will show albuminocytological dissociation, and MRI will show mild pontine lesion, and there will be a preceding infection. So how will you differentiate this MFS from Bickerstaff brainstem encephalitis? There will be triad in both these cases, although this areflexia can be present, or there can be hyporeflexia, or there can be hyperreflexia. Second thing is there will be altered sensorium, whereas sensorium will be intact here. And another thing is patient will have, so thus no this So no altered this consciousness in Miller-Fisher syndrome, and here will be positive Babin's case where there will be the negative. This will not be present here. No Babin's case sign, no Babin's case sign, and also MRI here will be normal, but it will show brainstem lesion, mainly in pons. So since we know that there are subtypes, for example AIDP, AMAN, AMSAN. So this is demyelinating type of lesion. This is axonal attack. And in demyelinating type of lesions, you know that there will be decreased conduction velocity, conduction block will be present, and temporal dispersion will be present here. So temporal dispersion will be present here, and there will be F wave abnormalities present. F wave abnormalities will be present here. So what are the types of abnormalities? Either it will be absent or it will be prolonged. So this F wave abnormality, either it will be absent or it will be prolonged. And CMAP amplitude, since it is a CMAP, amplitude will be normal because it's not axonal here, whereas it is decreased significantly early due to axonal degeneration in case of this in cases of Aman and Amsan. And conduction velocity is usually normal or maybe mildly decreased, and conduction block is absent. And temporal dispersion, although temporal dispersion, as we already mentioned, temporal dispersion is very common here in kinds of demyelinating lesions, but it is very rare here. Temporal dispersion is rare. And FA abnormalities which are common here, FA abnormalities, it can be absent FA or prolonged FA, and it is less prominent here. It's less prominent here. And what is the timeline of this GBS? You see, timeline is progressive phase, then comes the plateau, then comes the recovery phase. 2 to 4 weeks is the progressive phase. Similarly, 2 to 4 weeks is the plateau phase. Then recovery takes weeks to months. One important thing was this bilateral seventh nerve palsy that occurs in GBS is always elementine. It's always element. So when to start treatment in GBS? So you have to start the treatment as soon as diagnosis is made, especially in the following settings. When a patient is non-ambulatory. When patient is non-ambulatory, that is, patient can't walk greater than 10 meters. That too unaided. So patient is non-ambulatory, patient can't walk more than or equal to 10 meters unaided, and there is this rapid progression of weakness. So this one criteria under there is rapid progression of weakness. Third is bulbar muscles are involved. Fourth is there is respiratory compromise, so reduction in FEC. 5 is severe autonomic instability, for example BP, heart rate swings are there. So as per Harrison 22nd edition, immunotherapy is most effective when initiated within 2 weeks. So immunotherapy is most effective when initiated within 2 weeks of onset of weakness. And dose of this IVIG, we know which one is to be given, whether IVIG or plasmapheresis. IVIG or plasmapheresis, we know the dose of IVIG is 0.5 grams per kg per day for 5 days. So 0.4 grams per kg per day, and it is to be 0.4 grams per kg per day for 5 days. For example, a 60 kg individual multiplied by 4. So you give 24 grams OD for 5 days, and timing is within 2 weeks of onset, and efficacy is equal to that of plasmapheresis, and it's easier to give, and in children it's preferred, but never combine IVIG with plasmapheresis. There is no added benefit. Plasmapheresis you have to give around 4 to 6 exchanges over 10 to 14 days, and it is to be given within 2 weeks of onset. It needs catheter and setup, but less commonly used. So patient is non-ambulatory, so can't walk more or equal to 10 meters unaided. Second is patient has developed rapidly progressive weakness. Patient has and this involvement of bulbar muscles. There is respiratory compromise in the form of decreased FVC, and there are severe autonomic symptoms. For example, BP and heart rate swings are there. In such cases, you have to initiate either this IVIG or you have to give plasmapheresis. Note that is treatment effective after 2 weeks. So this treat after 2 weeks of symptom onset, benefit of IVIG or plasmapheresis is minimal. Benefit is minimal in patients who are already improving, but it may still be used if patient is, but it can be still used if patient is still progressing or not yet ambulatory. If patient is not yet ambulatory, or if patient has bulbar or respiratory involvement and that's continuing. So don't start IVIG or Plex in a patient who is already recovering and walking independently even if weakness persists. Steroids are not recommended based on randomized controlled trials and Cochrane meta-analysis, be it oral or IV steroids. So they do not improve outcome. And it may delay recovery and increase complications. Relapse within 1 month. So there can be relapse in less than 4 weeks. That's called as treatment related fluctuation. It is seen in 5 to 10% of the patients after initial IVIG, usually within first 3 weeks after treatment. So yes, in TRF what is to be done? Yes, repeat another course. You have to repeat another course of IVIG. You can use the same dose or do plasmapheresis if not done earlier. So GBS treatment is you treat early and once. If not working, treat. So if patient is not working, you treat. If relapsing less than 4 weeks, in 4 weeks, that's called treatment related fluctuation. You repeat the treatment. And what about steroids? No role.